the International College of Surgeons, United States section. Our topic today is colorectal emergencies. We'll focus on a couple of topics that can make a challenging call for the on-call general surgeon. I am your host, Dr. Rob Amajoy. I'm a colorectal surgeon here in Kansas City, Missouri. This afternoon, we have fantastic speakers and panelists. Our first speaker is Dr. Philip Condilis, who joins us from Florida. Dr. Condilis is a very good friend of mine. He is the program director of the General Surgery Residency Program in the Greater Orlando Surgery Program. He is joined by Victor Cabrera, who is a fourth-year general surgery resident, who's going to give us a case presentation. Our second speaker is Dr. Izzy Obohari, who's going to be talking about complicated sigmoid diverticulitis. Dr. Izzy Obohari is also a great friend. He's been about 10 years out. He's a colorectal surgeon in the great state of Texas. And we have a wonderful panelist, Dr. Erin King Mullins, who is a colorectal surgeon in private practice in Atlanta. And welcome. Without further ado, let's have Mr. Condilis present colorectal obstruction, malignant colorectal obstruction. But before we do that, we're going to talk about the objectives. The objectives are, one, you want to understand the algorithm of the management of malignant colorectal obstruction. We're going to review the complications and outcomes of colonic stenting for these obstructions. We're going to review the indications and contraindications for stent placement. We're going to review the data on emergency surgery versus stenting. And then we're going to review the current management of Hinge 3 and 4 diverticulitis, and then conclude with the clinical trials for laparoscopic lavage of Hinge 3. Dr. Condilis, go ahead. Thank you very much for joining us.
Good afternoon. Thank you for the opportunity to present today. If we can go to the next slide, I am happy to announce that I have no financial interest, arrangement, affiliation, anything that could be conflicting in interest. And we can move on to the next slide. When a patient is sent to me with malignant colorectal obstruction, sadly, the first thing I have to do is ensure that they're actually obstructed, especially when they come to the office. Not uncommonly, people will exaggerate the degree of obstruction. So it's very important to sort that out early. Not uncommonly, they're described as obstructed completely because the scope wouldn't traverse the lesion, or there was some other technical issue that limited advancement of the scope, or it was a suboptimal contrast enema examination. People who are truly obstructed are compromised. They have fluid and electrolyte, often nutritional challenges, so these need to be promptly addressed. And go to the next slide. I classify these folks into proximal obstruction, left-sided obstruction, and rectal obstruction, and their managements are somewhat different, and their controversies are a little different as well. Next slide. For my purposes, most folks presenting with a proximal obstruction, which for me would be proximal to the splenic flexure, they're usually resectable. Not uncommonly, they're reconstructible. If a patient comes and they're resectable, but they're incredibly frail, or they've recently had a stroke, they need their carotid done, they have coronary artery disease, they have a balloon angioplasty that has to be done, that's the very rare situation where I would consider someone who's resectable a candidate for a proximal type of stent. Historically, folks have avoided right-sided stenting. However, the data is showing that it's becoming a much more reasonable option. The patient who's unresectable is a whole nother category. They have very advanced local disease. They have horrible metastatic disease. These are folks who would theoretically benefit from a palliative stent more so than a bridge to surgery. So these are folks which I would say make up the majority of the patients who are candidates for right-sided stenting. And the next slide. Special challenges, these folks need to have a distal bowel prep. If you cannot easily get the scope there, it can be hard to stent a right-sided obstructing lesion. There are folks who will place stents with just endoscopy or just fluoroscopy. A right-sided stent especially really needs both. I would be very leery of doing it with a single technology available. There are also some special challenges. The stent caliber is much smaller in proportion to the luminal diameter than on the left side. The stents don't always look beautiful when they deploy. They're not necessarily maintaining a 0-degree angle relative to the luminal axis, but to be functional, they just have to be decompressive. One has to be careful that in a very proximal lesion, albeit relatively uncommon to be obstructing, you have to be certain that the stent can open and fully deploy without impacting the ileocecal valve. You certainly don't want to make things worse than they are. And then when a stent is in that position, sometimes it can be very hard to pass enough wire to see it coil above the lesion. That makes me very hesitant about placing a stent and having a window of safety between it and the valve. Next slide. Left-sided lesions, they have a very long history in the literature, going all the way back to Turnbull and blowhole stoma and three-stage management. I mention that really for historical purposes. This is very rarely done anymore. The classic and more modern two-stage approaches are to either proceed with a Hartmann resection or resect with reconstruction and a proximal diversion. Of late, there's even more resection and primary reconstruction without proximal diversion happening. The options in terms of pre-procedural decompression, the self-expanding metallic stent, which is by far has the lion's share of the use in this fashion. There's also a transanal decompression tube. It has its own body of literature. It's relatively uncommonly performed in the US. It's much more commonly performed abroad. I have to admit, I've never actually placed the transanal decompression tube, but on reviewing it, it's not unlike the placement of a decompression tube for Ogilvy's. It has a couple modifications to make it more durable. And I'll take the next slide. Here, simply just an image of the metallic stent. I'm showing a bare metal stent because that's really the only one that I would recommend in this setting. There are many manufacturers. They have slightly different sizes, different calibers. The probably biggest difference amongst them is the marginal contour. At the end of the stent, some will literally have bare, sharp metal, and some will curve back on themselves and provide more of a blunt profile. That's especially significant if you're going to pass a scope through it, or if it's really low and people will be doing digital rectal examination. You want to be certain not to destroy the sheath of the endoscope, nor develop essentially a needle stick on digital rectal exam. The metallic stents have been around for 30 years. They have a substantial body of literature. Really, the only big new change is that outside the US, stents that are manufactured with the intent of being removable are approved. To my understanding, they're not quite available in the US yet. I'll take the next slide. Stenting. In Europe, there are places where much of the stenting is done fluoroscopically by interventional radiology. In the US, there are surgeons who place stents predominantly just with the endoscope without fluoroscopy. My personal preference is to have both available. I think it makes it easier, safer, better. I really would hesitate to place a stent without having both modalities available. Next slide, please. Overall, stenting outcomes are quite good. The primary concern with stenting is perforation. Everything else is manageable. The literature has a widely varying description of the risk of perforation. Modern large studies show a 4 to 5% perforation rate. In more technically challenging situations, the rate is closer to 8 to 10%. You have to be very realistic with the patients when you discuss that with them. It's not a 1 in a million complication or a 1 in 100,000 complication. It is a real clinical concern, and they have to be accepting of that. Next slide, please. The decompression tube. I've never held one. I've never placed one. It does resemble crudely a pseudo-obstruction decompression type tube. You can place it over a wire colonoscopically. It has a balloon to help maintain it above the height of the lesion. It has a dilator to allow you to dilate the lumen of the tumor to pass the tube above. It has an irrigation port to help maintain patency. My primary concern with it is that its caliber is much, much smaller than that of a stent. So I'm hesitant to believe it gives the same degree of decompression. Also, it requires a dilation, which in general is something that you would not do if you were placing a stent. I'll take the next slide. Rectal obstructions, these are amongst the more challenging patients to stent in many ways. It's easy to get to the tumor, but the management of the tumor is more individualized. These obstructing rectal cancers are usually locally advanced. Not uncommonly, they have lymphadenopathy. Not uncommonly, they've compromised the mesorectal fascia. And not rarely, they've invaded adjacent structures. So these are much higher risk patients to stent. In general, I believe that the more circumferential and the thicker the tumor, the greater the risk of perforation. When I discuss these stents with patients, I describe the 10% perforation rate so that they are eyes wide open about choosing to proceed. I'm also very frank with them about the oncologic compromise that would come from a perforation. These patients, they're essentially all candidates for neoadjuvant chemoradiotherapy. And if you can stent them and allow them to have neoadjuvant chemoradiotherapy, I think that benefit for 90 to 95% of patients outweighs the detriment to the 5 to 8% that will perforate. My other concern is that these big, bulky, locally advanced lesions are at significant risk for a non-R0 resection. I think stenting allows more of these people to undergo neoadjuvant, be downstage, and undergo a oncologically better R0 resection. Take the next slide. So I do everything I can to avoid having to primarily resect these people. And the next slide. Decompression options. It boils down to stoma or stent or decompression tube. The medical oncologists love the stoma. It's been around forever. Every hospital in America can make a stoma. The oncologists consider that to be putting the obstruction on autopilot. They feel like they can do anything they want at that point. The patients all prefer stents. They don't want a stoma if they can avoid it. It allows them a better chance in the long term of ending up stoma-free. They have to be understanding of the risk of perforation. If the patient family, the patient decision makers are unaccepting of that risk, then I would not place a stent. Next slide, excuse me. So challenges, especially when you're in the lower part of the lower third of the rectum, you have to be incredibly aware of where you are relative to the anal rectal ring, the levator, the anal canal. Classically, you want 2 or more centimeters of margin below the stent. In the lower third, you don't always have that. You have to be very descriptive to the patient in regards to the risks associated with stenting low in the rectum. You can end up in a situation where there's persistent incontinence, proctalgia, tenesmus, and you want to do everything you can to avoid that. Next slide. If you place a stent that low and you have troubles, you have some options. You can simply remove the stent. You can go ahead and transanally with a steel suture scissor, you can literally tailor the end of the stent by cutting off the lower aspect of it. Nothing will get the rep to run out of the room faster than that. And there have also been descriptions of folks using argon beam coagulation to literally melt back the lower tip of a metallic stent. Next slide, please. All right. I have a short case that illuminates all the challenges of very low rectal stenting. And I will turn the discussion over to Dr. Cabrera-Boo. The rest of my slides can be omitted. We can go directly to Dr. Cabrera-Boo.
Before Dr. Cabrera comes in here, can everybody hear me? Excellent review, Dr. Candelas. Just learned quite a lot from that. This basically highlights your experience and the length of time you've been in the field. If you're joining us and you're watching, I want you to know that you're watching our inaugural 60-minute webinar series of the International College of Surgeons, United States section. Our topic is colorectal emergencies. You just heard Dr. Philip Candelas go over management of malignant colon obstruction. We're going to have Victor Cabrera, who is a general surgery resident, now present this case. Victor, go ahead.
Yes, sir. Well, good morning and good afternoon for someone's. I will be in line with Dr. Candelas' talk, which was a great presentation. I will be presenting a case of a patient that underwent a stent, low rectal stent. So this is a 63-year-old female who presented with abdominal distension, associated pain, and diminished stool output. Upon evaluation, this patient has physical findings consistent with distension, tender upon palpation, and upon rectal examination, she had a bulky fixed mass, which was around 5 centimeters roughly from the anal verge. Imaging studies revealed a large bowel obstruction with a high-grade stricture with a minuscule residual lumen. Important to remark about her history, this patient has never had a colorectal surveillance. Next slide. So part of the workup that we did when the patient presented, upon arrival, she has some few electrolyte derangement, which were properly corrected secondary to MSS and dehydration. As I previously mentioned, the digital rectal exam, this find a lesion around 5 centimeters from the anal verge, a CT scan of the abdomen, which will be appreciated, and I will be discussing that in the next slide. As well, we did some metastatic workup. The CT chest did not show any evidence of lesions in the chest. Unfortunately, we don't have a 3 Tesla MRI, which will be the gold standard for staging for rectal lesions. So we had a 1.5 Tesla. Patient underwent the MRI, which showed a distal rectal tumor, which was staged as a T3N0, which absent sphincter involvement. Also, we did a contrast enema, which did not show any retrograde feeling from the rectum. We will appreciate that in the next few slides. And we end up doing a flexible sigmoidoscopy for diagnosis, which did reveal a 5 centimeter lesion from the anal verge using a adult olymposcope, which was we also identified there was a symmetric concentric variable near-obstructed mass with some bulging of the mucosa. Next slide. So here we can appreciate the CT scan that I previously mentioned. As we can see in the coronal view with the red arrow, we can see this severe stricture, a significant stricture in the low rectum with, as imaging B reveals, there is a diffuse small bowel distension associated as well with some colonic distension. Next slide. So the gastrographic enema, as promised, did not show any retrograde feeling, which usually tends to happen first than anterograde feeling. So we did not appreciate any contrast moving forward. This triggered us, next slide. This triggered us to undergo a sigmoidoscopy. And as we can appreciate here in this imaging, definitely a bulky, solid mass with a minuscule at opening or lumen, as we can appreciate, was right there where the bubble is. That was considered to be amenable for passing a stent, passing a wire and subsequently a stent. We took 6 biopsies, were taken to pathology. Next slide, please. So pathology demonstrate here, as you can see in the imaging, we see disorganized part of glands with increased mucin-producing cells. It was diagnosed as mucinous adenocarcinoma. Next slide. We, after extensive discussion with the patient in regards to her pathology, she was offered either surgical decompression with a loop colostomy or an endoscopic decompressive stent. We discussed the risk, the alternatives, the complications, and benefit of both surgical options. She opted to proceed with the minimally invasive route, which was the endoscopic decompressive stent placement. And given the anticipating challenging low rectal stent placement in this particular case, she was additionally consented for a transanal revision of the stent in case we had to truncate the caudal aspects of the stent, which thankfully was not the situation in this particular case, but she was appropriately educated about this possibility. So we were able to deploy a 2.5 by 9 centimeter wall flex colonic stent just above from the anal ring, sparing the sphincters and those important structures. And a brisk colonic decompression was appreciated in the intables. Next slide, please. So she experienced sort of a fecal incontinence and some malproctalgia in the first 12 to 24 hours, which were resolved spontaneously. Prior discharge, we did a contrast edema, which just not which demonstrated the patency of the stent and excluded any synchronous lesion proximally. And to conclude, so historically, self-expandable metal stent has been avoided, and actually, some authors say that some endoscopies have been considered to be contraindicated on low rectal position lesion. Nowadays, with the new data that we have, there are some endoscopies that are willing to do it in some particular case, and it's supported by the data. So in our case is an example of an uncommon complication of a cell-limited fecal incontinence with very low rectal stenting. This case illustrates that stenting can be very effective in low rectum. However, it has greater technical challenge, and the patient must be taught and educated about the risk, complications, and benefits. And in this particular case, the decompressive stent avoided the patient undergoing an invasive procedure as a bridge for surgery, and the patient is currently receiving chemoradiation. Thank you. I take any questions.
Excellent case presentation there, Dr. Cabrera. So we're going to have Dr. Candelas come in and have the panelists come in. Interesting case. I've not stented a rectal cancer yet. I think I may try it started from today. So, this patient still has a stent, and he's going to carry it throughout his chemoradiation period. Is that correct?
Yes, sir.
Okay. Dr. Candelas, I have a few questions for you. When do you decide that the colonic stenting is contraindicated? Even after you stent these patients, like, how do you follow them? Like, serial abdominal examination? What do you do? I think he's muted. Dr. Candelas, can you hear us? Okay. While he sorts that out, Dr. Erin King Mullins, you're in private practice in Atlanta. I know you're very active with the Astras as chair of the DEI committee. I met you a year ago and quite impressed with your activities. What would you say is your algorithm for managing obstructive rectal cancer over in Atlanta?
Thanks for having me today. So, just as Dr. Condilis kind of mentioned during his presentation, and I think you mentioned during your introduction, the care of colorectal cancer patients is so individualized these days. And we have so many resources available for treatment now. And so I don't have a defined algorithm other than number one, starting out with making sure we have a very thorough and complete history and physical. Also, if I'm consulted on a patient with an obstructing rectal cancer, define obstruction. Are we talking about something that's found radiographically? Is this something that is presenting as a clinical obstruction? A patient actually has symptoms. And when we talk about that, what are their symptoms? Are they completely obstructed, partially obstructed? Are they having nausea, vomiting, so they're unable to tolerate PO? Are they passing any flatus? Are they passing any stool? Are they only passing, diarrhea, or are they able to have solid stool? Other symptoms, abdominal pain, abdominal exam, so those are some of the things that you obviously have to, rule out acute abdomen and things like that first, and then based upon your radiographic imaging, whether or not they are near the point of perforation. And then, as we go through that point, if determining whether or not, what resources do you have immediately available? Is this the middle of the night? And, ideally, maybe you would like to stent the person if you have the opportunity, but, it's the middle of the night on a Saturday night. So, all the radiology department may not be there to do fluoro to help you with a stent if you want to place it, and so you have to do a stoma. Those are some of the things that I kind of think about. And then also, what is the patient's current clinical status outside of their immediate presentation, and how sick or frail they may be? Are they really young? Are they really old? If they're of age to have screening colonoscopies, are they up to date with that screening? Was this found on colonoscopy, so do we need to clear the rest of the colon first, or not? Are they at risk for having some genetic a genetic disorder that needs, that they're likely to have some other concomitant, GI or colorectal malignancy. So I just said a few things, but so honestly, that's my algorithm. My algorithm starts with understanding the patient, their presentation, what their history is, and what our goals of care and their outcome is, and then you kind of go down those paths of stoma versus stent versus tube, rectal tube or decompression tube, just kind of based upon all of those answers.
Great comments there, Dr. Aaron King Mullins. And I echo the same, and this is what I do. There's really no one trick pony for any of these. You just have to sort it out, depending on what you have and where you are at. Dr. Condolis, do we have you with audio capabilities now?
I am back.
All right. Okay. So I was going to ask you, what question I was asking you is when did you decide that the colonic stenting is contraindicated? And because sometimes, even after the stents, how do you follow these patients? And when do you operate on these patients, especially the ones with the colonic stent and not the rectal stenting?
Colonic stent, these are all going to be bridge to surgery folks for the most part. The very small minority of those are palliative. The question is, why did I stent them in the first place? If this was, they had some other medical condition, they had to be supported through it to be a better candidate for surgery, then when their carotid is done or their coronary is ballooned or their horrible hypothyroidism is corrected or their arrhythmia is treated, they've been decompressed, hopefully they had a little bit of prehabilitation, I operate them as soon as they're medically stable to be operated. There's no plan to downstage them. I don't think that in the absence of wide metastatic disease that they need chemotherapy. They need resection, usually with primary reconstruction when they're medically suitable for it. They're, for me, relatively straightforward candidates.
Yeah.
The more distal we get, the more complicated it becomes.
We're going to get in a couple more questions here before we move on to the next section. But one other question I have for you, Dr. Condilis, is there a difference in the long-term oncologic outcome, emergency surgery versus stent to bridge surgery? Um,
I would opine that there is not. Certainly nothing that's proven.
and how
Uh,
like
if you look at ESCO, you look at CREST, you look at some of the work coming out of Japan and South Korea in the last year, they're showing data that at the 3 and 4 year time frame, disease-free recurrence, overall survival, time to progression, they're all very comparable rates between folks who had immediate surgery and those who were stented as a bridge to surgery. The ancillary data shows that they're less likely to have stoma. The only area of some concern is the very vestigial cell-free circulating tumor DNA work. That type of research is in its infancy. There's some data that says if you stent someone, the levels go up, but no one knows what that means. There's some data to show what it means if someone has a resection and their levels stay high. But a bump with stenting is a highly investigational area that certainly doesn't rise to the level of treatment planning.
I agree. Yes, I agree with that, and that's what I've seen. One last question before we move on to the next section is Dr. Easy. Dr. Easy, I've known you for a long time. I know you've done a lot of stents. Can you walk me to how you set yourself up for success for these procedures in the great state of Texas?
Well, first of all, thank you for inviting me to speak today. When it comes to stent placement, there are some things I have to think about first. Not every patient is a candidate for stent placement. You have to choose the right patient. And this is what I look at. Is the cancer completely obstructing? If it's completely obstructing, you cannot put a stent in because there's no lumen to pass your wire. If it's only partially obstructing, you may be able to get away with putting the patient on a laxative. So the patients that are best for a stent are those who are nearly obstructed, that have a pinhole lesion, and are also constipated. So the steps I take to set them up is this. First of all, my indication for a stent is for two reasons. It's a bridge to surgery, which means they are completely obstructed, they need a bowel prep, or they have impending colonic ischemia proximal to the obstruction. So it's a bridge to surgery. And the second thing is palliation. If a patient is too sick to undergo any major surgery, then stent may be good for them. So the first step of stent placement is making sure the lesion is in a location you can put a straight stent. So splenic flexure, hepatic flexure, distal rectum are usually very hard for stent placement just because of the anatomy of the colon. It's curved. You have a higher risk of perforation, stent migration, and other complications. So the first thing I do is I give them an enema, make sure that they're clean from below. I do a colonoscopy. If I find a pinhole lesion, with fluoroscopy, I can try to make sure the proximal portion of the cancer is open, and I can pass a guide wire. The guide wire is passed under fluoroscopy to avoid any perforation, and then the stent is deployed. I have used different stents, from bare metal stents all the way to esophageal covered stents. I think it doesn't matter what stent you use, but it depends on how you deploy it. You have to make sure you deploy across the lesion all the way. I try to avoid putting a stent in a stent because they tend to get occluded with stool in the short future. Before discharge, they are sent on a laxative, which they have to take a couple of times a day. And before the procedure, I counsel the patient about stent migration, which is very common. While they get treatment with radiation, the stent always falls out. So I tell them to expect that to happen. If the stent is too low, they may have some tenesmus, like Dr. Condilas mentioned. So I kind of warn them about that as well. But the key is to put them on laxatives after the stent is placed. I hope that answers all the questions.
Excellent. Thank you. Excellent comments there. For the interest of time, we're gonna start to move on to the next section. If you are joining us and you are here, you're watching our inaugural 60-minute webinar series of the International College of Surgeons United States section. Today's topic is colorectal emergencies. You've just heard the speakers, Dr. Philip Condilas and Dr. Victor Cabrera, talk about colorectal malignant obstruction. We learned a lot from that. And here we're going to now move on to another colorectal emergency that sometimes is not very straightforward. And that speaker is going to be with Dr. Izzy Obohari, who joins us from the great state of Texas. Izzy, go ahead and take it over.
Well, thank you for the invitation to speak on this topic, diverticulitis. For every one of us across the world, we have seen a patient or taken care of a patient with diverticulitis. So this is a very common problem. Next slide. I have a disclosure. I was a speaker and a consultant for Pacira Pharmaceuticals a long time ago. Next slide. So the objective today is to describe the common causes and the pathophysiology of complicated diverticulitis, also define the diagnostic criteria and workup, and also provide treatment options for complicated disease, and also necessary pitfalls to avoid. Next slide. So let's talk about diverticulosis and diverticulitis. So diverticulosis is a outpouching of the wall of the colon due to increased intraluminal pressure. While diverticulitis, as seen in this picture, you can see the dark, thick arrows. These are just showing areas of diverticulosis. But the thin arrow on the top right of the screen shows an area of diverticulitis, which is an inflammation of the outpouching. Next slide. When it comes to complicated diverticulitis, the complications can vary, okay? I think most of the time we have a hard time defining what complicated diverticulitis is. So the way to look at it is, if a patient has to remain in the hospital for a prolonged period of time, it is complicated, okay? The symptoms can range from just an abscess to a hepatic abscess. So across the world, the most common cause of hepatic abscess is not diverticulitis. However, it's one of the differentials here in the United States. A fistula can occur, a coloenteric fistula, a colovesicular fistula, which is what we see commonly. I took care of a patient a couple of weeks ago with a colofallopian fistula, which can happen. A colovaginal fistula is also very common, with the symptoms which we can get from the patients easily during a history and physical. A colocutaneous fistula is also very rare, but I have seen multiple cases of those with advanced diverticulitis. A coloperineal fistula is also common as well, and I'll give you a case presentation on that shortly. Perforation sepsis are common complications for diverticulitis. Also, long-term complications include stenosis, fibrosis with obstruction, and some patients, there's a subset of patients that have recurrent, persistent, or what I call smoldering diverticulitis. They have pain every week or every 2 or 3 weeks and just continuous. Also with diverticular hemorrhage, but that is not usually a complication of complicated diverticulitis. That occurs with diverticulosis. Next slide. Now, what is the pathophysiology? You have increased intraluminal pressure of more than 90 millimeters of mercury, and as a result, you have herniation of the mucosa and muscular defects. This is usually secondary to diet, especially with a low fiber, high fat diet and constipation. Diverticulitis can also be a big problem. It occurs mostly in males, and we're now seeing a younger male population being affected with diverticulitis. Next slide. The classical clinical presentations include left lower quadrant abdominal pain. That's why the diverticulitis is called the right-sided appendicitis or the left-sided appendicitis. You have absence of nausea and vomiting typically, with fever, sepsis, and septic shock in some advanced cases. In some of my patients, I've seen them presented with obstruction and as well as vague abdominal pains, like right-sided or left-sided abdominal pain. Pneumaturia, ficariuria, stool per vagina, or recurrent urinary tract infection. In fact, recently I saw a lady with recurrent vaginal infections, and the cultures were positive for E. coli. She ended up having a colofallopian fistula. Patients can present with an abdominal mass with erythema along the abdominal wall and a fistula as well. And there's also some other vague, unusual presentations. Next slide. Now, when it comes to the clinical diagnosis of diverticulitis, when a patient has left lower quadrant abdominal pain in the absence of nausea and vomiting with elevated white count or CRP, the sensitivity of getting diverticulitis is about 97%. So most of the time, the diagnosis can be made clinically, especially in regions of the world where a CT scan is not readily available. Next slide. when it comes to diagnosis, the diagnosis is best done by radiological diagnosis. You can use an ultrasound, CAT scan, or MRI, and each of them have a different sensitivity and specificity. Most commonly, CT scans are the acceptable way to diagnose diverticulitis because it helps with the staging of diverticulitis. Next slide. The classical way to stage diverticulitis radiologically is by the Hinchey classification. For this talk, I'm talking mostly about stage 3 and stage 4 diverticulitis, which involves a large abscess or feculent peritonitis. Next slide. So sometimes, other than the CT scan, which is seen on the right of the screen, on the left side of the screen, you'll see a barium or gastrographic enema, which can show you a narrow, long segment stricture. This is different from a cancer, which is usually an apple core lesion. So with this, you can understand the patient can have an obstruction with fibrosis and chronic inflammation. Next slide. Now let's talk about a case presentation. This is an actual patient I took care of recently. A 66-year-old male who presents with abdominal pain. His chief complaint was abdominal pain and multiple perineal fistula. In fact, the GI doctor called me thinking that he had Crohn's disease because of the fistula. He had pain worse in the lower abdomen with extensive perineal fistulas, no prior colonoscopies. The attempted colonoscopy was incomplete because of the partial obstruction of the sigmoid colon. He had a 20-year history of smoking, and on examination, he had focal peritoneal signs in the left lower quadrant and the lower abdomen. His albumin was 2.9. He was very malnourished. He had normal kidney function, and his white count was 6. Next slide. So this is a picture of a CT scan done on that patient. You can see on the bottom of the screen, close to the coccyx, on the left of the coccyx, there's a perianal abscess or a tract. So this patient had complicated fistula draining down from the sigmoid colon, down the rectal wall, all the way to the perineal area. Next slide. Okay, as you can see, this is also another picture of the same patient. You can see the area of the fistulous tract just at the level of the rectal sigmoid junction. Next slide. And this is also another CAT scan on the same patient. You can see the obstruction as well at the sigmoid colon. Next slide. So the surgical plan for this patient includes one of the following: laparoscopic, robotic, or open surgery. So in this particular case, because this patient had an unprepped bowel with a very large sigmoid colon, I opted to do it open because the patient was also pretty sick, and I did not want to spend a lot of time waiting for the robot to be available, and it was late in the afternoon. So I did an X-lap with sigmoid colectomy. The colon was stuck to the ureter, so I had to do some left ureterolysis, and I gave him an end colostomy simply because he had incontinence and multiple perianal fistulas. Now, what are the pitfalls of this surgery? Of course, an ostomy. Either if your ostomy is not well placed, it becomes a big deal because of the wound complications from an ostomy. The wound management, nutrition, ureter injury, and vascular injury. In my practice, whenever I'm doing a patient that has a complicated sigmoid colon or pelvic procedure, I place ureter stents in my patients. In fact, I learned how to do them, so I do them in all my low colon procedures now. Next slide. The treatment for stage 2 and 3 is a little bit iffy, but when it comes to stage 3 and stage 4 diverticulitis, the treatment has to be individualized, especially if the patient is septic or if the patient is immunocompromised. With feculent peritonitis, surgical intervention is needed. It could be a Hartmann's procedure, which is a sigmoid colectomy and endostomy, or you can do a resection with an anastomosis, with or without a protective loop ostomy. Next slide. So this is just a picture of an open case of what a perforated diverticulitis. This is Hinchey stage 3. The patient was in septic shock on immunosuppression. You can see how much pus can reside in the pelvis. Next slide. Now, the multiple studies have been done to look at laparoscopic lavage for diverticulitis. In a resource-sparse environment that you don't have a radiologist available to perform percutaneous drainage of a patient that has diverticulitis, there have been studies looking at randomized control study looking at laparoscopic lavage versus open surgery or versus resection. One of the studies' latest trial, this was done in Europe, looking at about 133 patients randomized to Hartmann's procedure and versus anastomosis. The trial lasted for about 12 months period, and they found that in those that had the laparoscopic lavage, 95% of them were free of an ostomy in 12 months versus 71% that were free of an ostomy in 12 months. So this study kind of hinted that performing an ostomy may not be to the patient's benefit. Also, some other trials like the Scandiv trial, the LAP-LAN trial, the Delilah trial, they have also hinted at that. But one thing we have to realize is most of these patients are healthy patients baseline without immunosuppression. Recently, I did a laparoscopic lavage on a patient who was receiving immunosuppression for rheumatoid arthritis. The patient failed the laparoscopic lavage because of the immunosuppression. So you want to make sure you tailor that to the patient. Next slide. With an open surgery, this is what the incision looks like. There's a long, recovery with patients that have open surgery. Next slide. With laparoscopic surgery, on the other hand, the recovery is much faster. Next slide. Most of my practice now, I do robotic surgery for most patients. The recovery is much faster. The incisions are much smaller, and patient can be discharged in 24, 48 hours after their sepsis resolves. Next slide. And this is what the specimen looks like typically, especially in patients that has extensive diverticulitis. You may have to remove more than just the sigmoid colon. You may have to do a formal left colectomy. Next slide. Now, when it comes to colonoscopy after diverticulitis, the diverticulitis, most patients that are healthy with a low risk for colon cancer do not require routine colonoscopies. However, if they come in with complicated diverticulitis, doing a colonoscopy is prudent because in a study done, showed that about 6% of patients had low-grade adenoma in addition to the diverticulitis. Next slide. The recommendations from the American College of Surgeons and Rectal Surgeons suggest that colonoscopy should be performed after the resolution of diverticulitis. Typically, for my practice, I wait for about a month before I do a colonoscopy. Elective colectomy is an individualized process. Next slide. And of course, when it comes to performing an anastomosis, you want to weigh the patient's risk for a leak. If the anastomosis can be done safely, according to the latest trial and the Scandiv trial, that may be better for the patient long term. But again, you want to make sure you tailor your treatment to the patient. Next slide. In conclusion, the diagnosis is usually clinical for diverticulitis. A CT scan or ultrasound can be helpful. However, it's a clinical diagnosis, and close immediate management of patients with complicated diverticulitis is prudent to reduce mortality and morbidity. Next slide. And Hartmann's procedure is not superior to resection and anastomosis, especially in the patients that are healthy and are not immunosuppressed. For my practice, to get the patients ready, I make sure that they're prepped if possible, and I put in a ureter stent to help with identification of the ureter intra-op. Thank you.
Excellent. Excellent review, Dr. Bohari. Let's bring in the panelists. I really like this. This is a very good review. Dr. Gonzalez, let me start with you. You've been doing this for over 20 years. You were the program director of a colorectal surgery fellowship program, which is where I attended my colorectal fellowship. You are now the program director of a very good surgery residency program. What are you teaching these residents about how to manage these patients for diverticulitis, especially Haitian 3 and 4? You are muted.
Apologies for the mic there. Everyone is moving more towards resection and reconstruction. And as the years go by, people are moving more and more to doing that, even in the absence of a diverting stoma. Everyone sort of finds themselves along that spectrum, I think, moving in that direction now. The data is that For otherwise well patients, it's very well tolerated. Sick patients make me more conservative still. It's all about, when folks have complicated diverticulitis, is it drainable percutaneously? If it's not, can IR drain it? If IR can't, can I drain it through the rectum? Can I drain it through the vagina? Do I have to laparoscopically drain it? And then I let them get better, and then I want to do everything as electively as I can down the road, whenever possible.
Excellent. I mean, you've seen the progression over the years.
I have.
Yeah.
No, if you did anything but a Hartman 20 years ago, you were a radical.
Exactly.
You were to be condemned.
Yeah.
It's changed a lot.
Exactly. So, Dr. Easy Obohari, again, great presentation. You know, you have that patient with hemp-3. Can you walk me through how or what you tell these patients before? Because for me, my experience has been like every time I offer them the laparoscopic lavage option, they take it because they don't want it back. I tell them that they have a very high chance of ending up with a colostomy if I take them to the operating room. How do you get them to pick which modality that you're going to treat it with?
Well, that's a very good question, Rob. So when I talk to a patient that is, like either if they're on the floor and not in the intensive care unit, they may be a candidate for lavage. So I tell them the plan today is to do this. We'll do a laparoscopic evaluation to see if I can drain this laparoscopically. If I can't, I'm going to move ahead and do a resection. A resection with a chance of a primary anastomosis, which can occur in less than 50% of the time. The other times, I end up giving them a colostomy. So I get the patient prepared for everything, all the way from a lavage to getting a colostomy. And I tell them my goal is to prevent a colostomy if I can, but their health comes first. So I get the patient marked for ostomy. I mark them on both sides for an ileostomy and a colostomy. I start off laparoscopically. If I have good ease of entry and I can find the fistulous tract or the area of perforation and put multiple drains, good, then we're done. But if it's a very large opening in the colon and the patient appears to be in septic shock, I will end up doing a resection. And depending on the patient's health, I can put it back together with a loop ileostomy. If I can do that, I give them an end colostomy, come back and fight another day. That's the way I kind of treat them.
So, quick question. In the era of robotic surgery and robotic takedown of colovascular fistula, how do you manage the opening in the bladder these days? You know, I mean, before a robot, we just pinch it off, right?
Yes.
We pinch it off, we move on. And that's how, at least that's how Dr. Condilli taught me when I was a fellow. But in this day and age, how do you manage that opening? Especially not openings are created equal, right? Some openings are pretty large. How do you manage that? And how do you manage the cystographic test of the bladder post-operatively?
Okay. So fortunately enough, I do cystoscopies on most of my patients. So for patients that have a fistula, I would do a cystoscopy pre-op, put in the ureter stents to make sure I can identify the trigon of the bladder.
And you put on the stents yourself, right?
Yes, I do the stents myself. I feel it's a little more time efficient.
What did the urologist say about that? Well,
so I got privileges by being trained by the urologist, and they were very happy about it. Because
they don't want to come in.
It saves them having to come in at 4 o'clock or 5 o'clock to put in a stent, or waiting for them before they start their clinic. So I got proctored, and I have privileges to do cystoscopies. But for cases that are super complicated, I have a urologist on standby, available to help with it. Now, fortunately, most of the time, the fistulous tract is a pinhole. It's a very, very tiny opening. So my process is I oversaw the fistulous tract. I try to make sure I get healthy bladder, imbricate it with a PDS suture, like a 3O PDS or 2O PDS suture. Then I do a leak test of the bladder with methylene blue. So I check out I inflate the Foley with methylene blue, and I check for extravasation. And if everything goes well, I do not typically get a routine cystogram post-op. However, if it's a complicated patient with diabetes or immunosuppressed patient with a complicated procedure, I routinely do a cystogram.
Okay. Dr. Candelas, anything?
No, I would ask when you repair the bladder, do you mobilize the fat pad off the bladder to properly see the bladder?
Yes, most of the time the bladder is still very pliable, most of the time. But if the bladder is is stuck down, I do some mobilization anteriorly to have the bladder have some healthy tissue. But the key is to make sure when you close the fistula, don't close the fibrotic tissue around the fistula tract. It tends to rip, it tends to bleed. So I try to mobilize some healthy bladder around it to imbricate it and to close it in 2 layers if possible.
I agree with I try to mobilize a little bit, and then I use a V-lock suture to close this, um, and it tends to work out pretty well. I mean, I think with the visualization of the robot makes it very a lot easier to have a very good closure. Um, Dr. Aaron, do you have anything to add on that? I'm sure you've seen a lot of these over in the great bit of closure.
Yeah, definitely. And I know obviously management is going to be very institution specific. I applaud you, Dr. Izzy, for having, the wherewithal to get your training on placing stents, because we all know that, that can be a delay in care for some patients, if they really should have a stent and you're waiting for another team to place that. And, I'll just tell you, just in my institution, I always err on the side of caution in the sense of, I will typically just have the urologist place the stents. And if I do think that the bladder does need a repair, I will go ahead and just get them involved. You know, there are instances where, even if you have the youngest, most healthiest patient and you close that bladder exactly how the textbook showed you with all the pictures and it looked like netter, it still leaks. And then, then the question is, if there's a problem later, the urologist or whomever else is like, well, why didn't you just get urology involved? So, a lot of my just kind of thought process and all those things is just kind of surrounding that. And also long term, if there's any issues in the future, that they at least have that established relationship, with the urologist that can follow them should, anything go awry. But yeah, diverticulitis, it's just interesting that we're talking about the malignant obstructions and diverticulitis together, because diverticulitis can actually be a great equalizer, because it can be something that really affects multiple areas and quadrants of the abdomen and can be very complex and difficult to deal with, even more so sometimes than cancer, because of the diffuse nature of the inflammation that can be involved. So just great talks today so far.
Yeah. Thank you so much. There was a question from the audience. They want to know why it occurs in men mostly. Dr. Candelas, you want to take that?
Well, I don't have a fantastic answer. I'm not sold on it being a male-centric disease, diverticulitis. I see a lot of ladies with diverticular disease. I see a lot of ladies with diverticulitis. I think when folks have had serial significant episodes or they've had a complicated episode, I think ladies are more willing to accept resection. I think men are just a bit hard-headed. And when they come in, they tend to be sick and perforated and have had multiple prior bouts and just generally more miserable cases. I'm not sure it's a true gender disparity.
I agree with that. I think
And I'd like to jump in just really on that, because I've had, some students and kind of people ask me, and I think, just through experience, I think one of the things is, women typically have quote unquote an atypical presentation, which may be, typical for them based on the varying anatomy. And so I think sometimes there's a little bit of a delay in diagnosis, in the sense of, there's a concern for some sort of gynecologic issue, maybe even a little bit more of a urologic issue if their complaints are mostly dysuria, hematuria, or, something like that. There's a little bit more of confounders in the area for, I think, women. And so I think a lot of times it's just a delay in diagnosis or even potentially a misdiagnosis based upon their symptomatology.
All right. Thank you so much, guys. We do have a minute here left to wrap up, and I do want to go ahead and conclude. You have my conclusion slide here. Um, we know that stent placement in patients with malignant obstruction is indicated in palliation of surgical incurable colorectal cancer. We have learned that stenting as bridges to surgery to avoid emergent or two-step procedure to allow for optimization of medical status and proper staging, including colonoscopy, is why we do stenting. We all know that hyperperforation has been reported in patients receiving bevacizumab as a component of chemotherapy. Emergency surgery and stent to bridge surgery have both comparable short and long-term results in available data, and laparoscopic lavage may be a viable option for NHE 3 perforated sigmoid diverticulitis. Um, I would like to use this opportunity to uh, thank our incredible speakers for educating us on colorectal emergencies. Dr. Condolis, thank you so much. Again, I want to thank you once again for giving me the opportunity to become a colorectal surgeon. I graduated successfully from a general surgery residency program, but I'm a fellow because Dr. Condolis selected me to get excellent training from his program, and I cannot believe that years later he's on a webinar that I'm hosting. When I called him, he immediately said, I will do this. Thank you so much, Dr. Condolis. He's an incredible teacher, mentor. Victor, you are lucky to have him over in the great state of Florida. We appreciate our fantastic audience for staying with us throughout the show. A huge thanks to the production team for putting this show together. Thank you, Nick. Thank you, Maggie. Stay tuned for our next webinar. We're taking the Christmas break, and then this is a bi-monthly webinar, and the next webinar is going to be on January 14th, 2023. And that's going to be on management of penetrating bowel trauma. I will see you guys then. Thank you. Until next time. And we do have our participating, for our participants, all registrants will receive a brief survey shortly. And please complete it to help us prepare for future events. Thank you.